It's a pleasure to be here with you today. And of course, we all came in expectation of discussing pain management and restoratively driven endodontics. Is less really more? And we're really going to get into this, and I really want to frame a conversation dealing with obviously ways to manage pain. What is the literature state coming from an evidence-based perspective, but also coupling that with restorative endodontics, if that even is such a word. Okay, and what does that mean, and what are the goals, and is that a paradigm shift? Of course, I would be remiss if I were not to extend a sincere hand of gratitude to the Greater New York Dental Meeting for allowing me this platform to speak before you today, and of course the National Dental Association, which has been a staple in my backyard and a great support in terms of allowing me to progress and grow and network and just build great relationships with colleagues. We also have Coltine, who has generously supplied a possible hands-on portion of this as we move through the afternoon. We'll see how our timing permits, but over the years we have developed a great working relationship, and it's a pleasure to have them here with us, okay? So I always like to see who's in the crowd. Is anyone from out of state in terms of out of New York? All right, welcome and thank you. I hope that you were able to enjoy a nice weekend so far. The weather is not the best, but nonetheless, New York is an amazing city, and I'm so privileged to live and practice here. But just a word of caution, if you do take the subway and you happen to see all the cars are filled except for one, beware, okay? It could be a problem, so just go ahead and pack it in like sardines. Don't think that you're getting one up on somebody and try to get into that car, because you will be unpleasantly surprised, and I don't care how many face masks you wear, it's not going to be enough to kind of quench that situation. So just a word to the wise, okay? So without further ado, I digress, and we'll go ahead and get into it. But I should also mention, please, this is a forum of discussion. I want you to be very comfortable. If you have questions and I can answer them, I'm very happy to do that. This is really just a academic sort of discussion. And so I'm feeding off the energy that you guys are feeding me. We are here for at least a good 4 hours or so. And so, just give that back to me so I can keep going. Thank you so much for being here. So I think it's always important just to frame or kind of define what is pain, okay? And as you can see, I'm just going to read it. A multifactorial noxious experience, a painful experience that involves not only the sensory response, okay, but also modification by cognitive, emotional, and motivational influences related to past experience, okay? So think about that. This is direct quote from the AAE, American Association of Endodontists, a direct quote from our glossary of terms, and I wanted to have the most tooth-specific definition of what pain is, okay? And pain can come in many different forms, whether it's neuropathic, whether it's referred, trigeminal neuralgia, things of that nature. But for all intents and purposes of today's course, we're really going to try to stay within the vein of odontogenic pain, okay? Being able to diagnose that, furthermore, being able to understand how we can mitigate that, how we can manage that, so that patients ultimately have good patient outcomes and experiences because the pain has been diminished. I did want to draw your attention to the cognitive and the emotional. How much of pain is related to the psychology, okay? How are we able to deal with our patients and interact on such a front or a plane that they feel comfortable? Because we do know that there is an inverse relationship between anxiety and the threshold of pain, okay? The literature specifically states that, and we have to be very understanding of that connection. Past experience. How often does someone sit in your chair? You know what? I hate the dentist. Why would they say that if they haven't had a bad experience? Unfortunately, I hear that quite often being an endodontist, and I often joke that if I were to hear that and get paid, I wouldn't need to actually be an endodontist, because I hear it so often. I love my mom and she loves me, but even she says that, son, I love you, but I hate coming to see you. But I did have the chance to do a root canal back on her in 2012 when I first started out on building my practice. And that was the most, that was a noteworthy experience, because I realized that from that point on, I had to treat everyone with what I call the mother litmus test, okay? If this was your mother, what would you do? Now, if you don't love your mom, I can't help you. But if you love your mom, you can understand that adage, okay? So there's a little bit of science to the idea that I'm sure if you've heard, they say pain has no memory. Has anyone heard that saying before? Pain has no memory. Well, how can that be when someone sits in the chair and they're willing to share with you that they've had a bad experience? Obviously, the emotional component is there, and so we're going to get into that as well. First, let's just start here. Who would agree with this statement? Root canal saves teeth. Okay. Maybe some of you are more inclined towards placing implants, maybe not. But I agree with this statement. I think that this is truth, okay? The American Association of Endodontists, we have recently launched a national public awareness campaign, actually worldwide. And the whole focus is for first the public to value saving their natural teeth, and what else? To also understand the role of an endodontist within the spectrum of dental care, okay? And we really want the public to value saving their natural teeth because there is no substitute for what the good Lord gave you. So this was a case, patient came in, very hot tooth number 31. You can kind of see that it's close within the mandibular canal. So sometimes, we'll get into this a little bit later, how to manage these cases. But I just want to kind of start off just to engage you with a presentation, a case study, okay? Obviously, we see there's recurrent caries. At some point, I guess the general practitioner, whoever tried to restore that tooth, was unable to actually get a solid contact there. And we see that. It's a challenging area to restore. So after I kind of cleaned everything out, I was able to kind of see there was some decay. I went ahead and cleaned it out. As you can see, I'm isolated with my rubber dam. You know, I will describe this in a little bit later, but this is intraosseous technique. It was very hot tooth, as we say. Excuse me as I kind of move through here. So I needed to make sure that they were completely numb, so I'll stay on this side, so that I could actually enact high quality treatment. Thank you. Okay.
It was a hunt.
I owe you. Okay, thank you. Okay, so I was able to go ahead and do some root canal treatment, place the temporary restorative material, a dual temp, which is going to be sort of a dual cure temporary material. And oftentimes I'm inclined to restore my own cases, and I'll get into that story in a little bit. But proper pain management, proper root canal was executed. Obviously, instructions were given, return back to your general dentist. A year later, gingival polyp is growing into the space. Patient, obviously called the office frantic, oh, my tooth is killing me, what's going on? And I should probably note that at the time we also mentioned, please return to us after you get tooth number 31 restored, because we're gonna need to retreat this. We see this is a pretty active lesion. Unfortunately, I see this too often. And that's why I wanted to bring up this topic and show you why I have come to a conscientious, concerted effort to restore the teeth that I actually treat with root canal. Okay, this is a scenario, this is a narrative that unfortunately plays out too often, and it shouldn't be. Look at that. Okay, and literally this was almost a year to the date from when I originally treated the case. Nonetheless, he's going to have to get 2 implants if that's what he wants to do. He isn't the most compliant patient, so probably a year later, if I were to see him, he would probably just have an edentulous space. Who knows? Like I did mention, we do have Colteen, who is actually helping to sponsor this event, and we're going to discuss just some ways that we can actually manage cases from start to finish and also be aware of avoiding perforations, canal transportations, instrument fractures, and this is the biggest one, unnecessary removal of tooth structure. Again, the buzzword, restorative-driven endodontics, caries-directed access. These sort of terms as to allow us to prevent teeth from fracturing further, but also ensure that these teeth have strong restorative techniques so that patients can actually use those teeth throughout the rest of their life. Again, root canal saves teeth. Who now agrees with me? Has it changed? Maybe? And please keep in mind, I'm not one of these presenters who is going to pose questions to you and expect you to answer. I want you to feel very comfortable because I want this to be a dialogue. This is an academic setting, and we are doctors. So this is how we learn. This is how we grow. Feel free to engage, but it's really just a rhetorical question when I actually am posing these questions. Root canal saves teeth, right? So this was a case probably back in 2013, okay? Just to kind of show you my transition. There's maybe some recurrent caries under this occlusal restoration. Number 19, didn't think there was too much going on. Maybe a little apical resorption, but it could have also just been the angulation of the radiograph. Nonetheless, I diagnosed it as SIP-SAP. You'll hear me say that throughout the presentation. Symptomatic irreversible pulpitis, symptomatic apical periodontitis. And that is the new updated AAE diagnostic terms for diagnosing teeth, if you're not familiar with that. Complete the root canal. Now, at that time, I was more robust with my access, but nonetheless, I would say this was within the standard of care. I've always been a fan of resin-based sealer, epoxy resin, so it's going to show, and I like to have patency. Yes, sir.
Is the final film?
Yes, that is the final.
So why are you leaving a space underneath?
Excuse me?
Why are you leaving a space like this accountability? Why do you?
Oh, this right here. Yeah, this I'm showing you. This was in 2013 how I would practice. The dentist wanted me to temporarily restore the case and send it back for permanent restoration.
Yeah, but why is this space?
Oh, I see. Yes, this is a placeholder. No, this is a temporary, and this is cotton. So when the dentist removes this filling, they don't go actually into my canal preparation. Yeah, good. See, this is why we're here to learn. A question that I may have not considered was something that now allows us all to better understand where we're coming from. I love doing recalls. I'm a board certified endodontist, and I mention that to say that I got into the habit of always recalling my cases. Doesn't mean I'm better than anyone, just means I wanted to aspire towards that level of professionalism. So I'm always on constant recall of my cases. I brought this gentleman back in, and now I see that there is a furcation involvement, a little bit more periapical lesion here in comparison to the original film. Not too long ago either. So first of all, I was concerned because I'm thinking, well, what did I do wrong? I felt I had good instrumentation. I thought that I was able to work well within my space and good chemomechanical debridement. What's going on? So I was able to take a scan, and now we can see the presentation a little bit more clearly. Okay. Can anyone identify why this case has failed? Hmm? Sure. Is there someone? Thank you, Michelle. Let's give it up for Michelle in the back. All right. Where would we be without our helpers? She mic'd me up. She's been very pleasant. It's always a pleasure to come back and speak. There was no missing canal in this case. It was more or less an issue of the restorative complex, not really the endodontic complex here. And I'll tell you, right here is what we call the danger zone. For those of you endodontists, you're probably very familiar with Abu Ross, talks about the danger zone, the most mesial aspect of the distal root and the most distal aspect of the mesial root. Essentially, this can be perforated by what we call a strip perforation. That dentin is kind of thinned out. Next thing you know, you have communication with the oral cavity. Bacteria infiltrate the space, and you get that. But why did this happen?
Try to place the post and use where the gates would be.
Exactly, post placement. So again, it got me thinking, maybe I should really start to consider restoring my own cases. I was seeing so many cases come back where the restoration had fallen out, and then the patient never came back. Bacteria gets back in there, tooth fractures because it's not properly restored. The structural integrity is now in question. Or in this case, was there really, did this really call for a post placement? I don't know. I'm not a prosthodontist, but usually when there's four walls and there were here, you can't see three-dimensionally. My axis was a little bit big at that time, but nonetheless, I don't think that it really was indicated in this situation.
And you don't even have to do a crown in this case.
Yeah, and then we're going to look at some literature that highlights that by prosthodontists. Maybe a crown isn't even indicated. So then again, these are just cases, and I'm just kind of bringing you along a journey of my thinking and how I got to arrive at the idea of, it's an idea that's been around, but restorative-driven endodontics, and trying to incorporate that into my practice and really do a better service for my patients for better, healthy, long-lasting teeth. Restorative, endo-restorative complex, okay. So this is some of my achievements, this things, place where I study. This is really not important. The only thing that I want you to really pay attention to is Case Western Reserve. I would be remiss if I were not to sincerely thank my director at the time, Dr. Andre Mickle, who's now the chairman, and Dr. Jefferson Jones, God rest his soul, who was the original first chairman of that program. I thank them because they saw in me what I saw in myself, okay? And we all have teachers and we all have mentors, and these were very influential people in my life. But I also have this up for a second reason. This is New York City, and it's a dynamic city, and one thing I say is always be kind. You never know who you'll come across, if someone has a bad day or if they don't. But oftentimes in New York City, as an endodontist, I do get asked this question. Do you play for the, you kind of look like, yeah. There is a little bit of resemblance. If I do say so myself, he's a handsome guy. I don't know. Ask my mom. That's all that matters. As long as your mom thinks that you're handsome, you're fine. You know, if you call your mom and you have a bad day, oh, it's okay, baby. But she doesn't say that you're handsome, you may want to just start hitting that gym again. But in all seriousness, I put this up here because I don't take myself too seriously, okay? But I do take my craft and my patience at the utmost level of sincerity. And, you know, if we can't have a little fun, why do we even do what we do? This is Justin Holiday. He was a former New York Knicks player. Not really a friend of mine, but we were acquaintances. I'm in here in the Knicks locker room. And just to be clear, I am Dr. Johnson, Dr. J, the rec league ball player, not the professional. But the Knicks are so bad, maybe they could use me, you know? You never know. I still have aspirations to want to be LeBron James, you know, Tom Brady. I want to be like the greats. But just a little humor, let you guys know that keep it light. I think that we learn best when we are able to receive the word, and I want you guys just to be able to enjoy. So let's go ahead and get into it. These are 3 things that I think are very important for me, Kujichagulia. It's a word in Swahili which means knowledge of self, self-determination. If you don't know who you are, how you want to practice, how are you really going to define yourself? How are you going to define your reputation with the individuals you interact with on a day-to-day basis? Something that I've subscribed to has helped me tremendously in any and every aspect of my life. Quick story about the biggest room. My dad is a military man, and he'll have us, you know, my brother and I, we were young, doing push-ups. And one day he called me over, and he said, hey, Marcus, come here. But he said it with such an authoritative tone, I was a little bit concerned. I said, oh man, what did I do wrong, you know? Did he know I snuck out the house last night? Was it, you know, my mind was racing. And he said, you know what? I'm gonna ask you a question, and I need an answer. So now I really start to panic, you know, sweat's coming down my back now. Like, oh no, he knows I did something. And he says, son, what's the biggest room? I don't know, Dad, the living room. No, the biggest room is the room for improvement. Okay, and I've carried that with me throughout my life. And I should also, the room for improvement. Yes, room for improvement. And I do have another dad here who is my NYC dad, Dr. George Williams. This isn't my dad from my biological dad is in Denver, but once I did come out to New York, Dr. George Williams, who's here now supporting me, was pretty much my NYC dad. So it's a pleasure to have you here, Dad. And it's just always good stuff to see the support. Excellent dentist. He's been doing it for years. Medical College of Georgia and all that good stuff. Practice in Harlem. And to this day, he's still doing great work. So, and preparation plus timing. You prepare and you have the right timing, you equal success. Those things have allowed me to be where I'm at today, and I hope they'll continue me upon my path of success. So getting back to pain, are we even familiar with the term analgesia? Did I say that right? Sometimes my accent comes into play. I'm from the Midwest. Anesthesia, are they the same? Are they synonymous, or is it different? I'll make it easy for you. Relief from pain, just to be the most basic. Analgesics, over-the-counter analgesics, we hear that term. Anesthesia, a little bit different. Loss of sensation. Loss of awareness, maybe. Okay. So it's important that we understand this dynamic when we're trying to evaluate, first of all, is the pain of odontogenic origin? How are we going to mitigate and manage that pain? And are we going to bring them to a state of analgesia, or is it going to be anesthesia? Okay. And how do these come into play in the practice setting so that we can ultimately deliver great patient outcomes, patient-based outcomes? Influencers on pain. What's another word for this? Maybe we could say comorbidities, maybe? Would that maybe work? Yeah. We're all dentists, we're science, we can speak in that lingo. Factors that can affect responses to pain. Age. If you look at the literature, what are most of the studies? What are the age ranges that most studies are coming from? It's definitely usually not pediatrics, unless obviously we're studying a pediatric population. But as it relates to endo, we can maybe say, 18, maybe even 16, 65 or so, okay? So we're really not studying the farthest end of the geriatric population, or also the pediatric population. So there must be some sort of discrepancy there. How many of you have ever evaluated teeth for vitality with an older individual, and you take a look at the x-ray and there's a lot of calcification, you can't hardly see the root canal, right? And you test each tooth and there's no response, just as a baseline. Doesn't necessarily mean it's necrotic, but it just could be sclerotic dentin, right? So age. If we were to take that same test and apply it to a young 16-year-old, pretty sure they're gonna have a response in all those teeth. Phenotype. Who here has heard the evidence to support that natural redheads, Nicole Kidman type, are actually going to receive pain with the lower threshold? Right? Is there any validity to that? It's in the literature. How much of it is true, it's hard to say, but that is a phenomenon. Ethnicity, does that play a role? Does it play a role in how people actually follow directions in terms of how you direct them to take the medication? These sort of things, do they play a role as well? The ambiance, the space that we're in. If someone is presenting for a root canal in a very calm and nurturing environment, how is that going to affect their pain? How is that going to allow them to be more receptive to quality care and not have any issues? Anxiety, without a doubt. When you're stressed out, are you more likely to be irritated fast or not? Probably irritated, right? Yeah. Same thing. There is an inverse relationship, and we can see that. The anxiety goes up, the pain threshold goes down. The evidence does support that. Even in the medical literature, we can find that. Gender. By and large, gender does play a role. To what degree, it's hard to actually say, but we look at most of these studies, it's going to be focused on a male cohort more so than female. Now, as of now, things have changed, and we're trying to find studies that are equally balanced. But all of these comorbidities are things that you must consider when we talk about pain management. I love flow charts because it makes it so simple. It's a nice illustration, a diagram of just how things flow. Like I said, we're really going to stay to the right, okay? We're only going to be looking at odontogenic pain for today. No need for us to really venture into this space, but as clinicians, we should know how to properly refer. So if you can properly identify that the pain is of non-odontogenic origin, by all means, you should be able to make the proper referral. I am an endodontist. I am a specialist in managing and diagnosing odontogenic pain. Now, if I'm talking about atypical facial pain, I can recognize the sign, the symptoms are a little bit different, but I'm no expert in managing those cases. So by all means, here's the referral for the oral pain specialist. I'll follow up with you and see how you're doing, okay? Understanding how to refer, when to diagnose and differentiate. Risk factors for odontogenic pain specifically, not non-odontogenic, okay? I think this is a no-brainer. If a patient comes in pain, are they more likely or less likely to have post-operative discomfort? Yeah, the literature is replete. We'll get into obviously some classic landmark studies in endodontic. History of chronic pain, not just necessarily pain related to a tooth, but just a history of chronic pain, maybe some sort of fibromyalgia or even chronic fatigue syndrome. These sort of situations automatically put you at a disposition to develop odontogenic pain in the future. Palpation tenderness, percussion discomfort, inter-appointment odontogenic pain. If you're doing cases in 2 visits, that pain just really is not resolving. Does genetics have a play? I think so. I saw a patient who had cleidocranial dysplasia, very soft dentin, soft teeth. Unfortunately, she's at a disposition to now develop more odontogenic pain and issues because she just doesn't have the resistance to those, to the environmental effects in the oral cavity. And I put this one here as well. Oral hygiene instruction, is the patient neglectful? Yeah. All of these are major risk factors. There's always a pulpal and a periapical diagnosis. If you can't properly diagnose, how can you properly treat? I'm not going to beat you all over the head. This is just to let you know that you have to have the right diagnosis. We are dentists. We should speak in that jargon and understand the importance of that. And so we'll leave it at that. But just note there have been some changes. It's no more Phoenix abscesses, or we don't say chronic apical periodontitis anymore. Asymptomatic apical periodontitis. Understand these terms, know them, and being able to speak with your colleagues so that you have a fruitful discussion, and at the end of the day, everyone comes out on top.
Thermal means cold.
Yes. Oh, let me see. What was it? No, thermal is essentially evaluation of any extreme, hot or cold, thermal test. But ideally, it's going to be cold, but it can be extrapolated to mean heat as well.
The one all the way to the left.
Mm-hmm.
If there's any sensitivity to heat, it's already.
You're saying if there's this one right here?
I mean, even if we have a sharp pain that goes away quickly with hot, it's still not normal.
Usually, when it's discomfort to hot, that already means that what? The C fibers have been invaded. So you're already on the root to root canal already. Mm-hmm. Because remember, the cold will be stimulated by what? The A delta fibers. So when a patient is complaining of hot, we already know it's a problem and they definitely need to get that treated. Sometimes it can be reversible if it's just cold discomfort, but usually that lingering sensation will differentiate that. So in residency, we were all nerds, but we had a lot of fun and we used to play games. Let's figure out the diagnosis when there's no radiographs, when there's no images. So I'm just going to pose this to you guys. Chief complaint, I put this in parentheses because that's exactly how the patient stated it. We want to be as specific as possible. My tooth has been painful and hurts me when I bite. History of trauma 2 years prior, extra-oral examination, W&L. What does that mean? No, it means we never looked. Come on, guys. We weren't being thorough in residency, were we? We were just trying to focus on our boards. We never looked. No, you have to be careful when you put those terms in there that are so, I can't even say if it's subjective. It's just a term it's too expansive. I teach residents in Brooklyn, and I'm always on to try to be as specific as you can. The devil's in the details, okay? Intraoral examination, mesial incisal composite restoration. Aha, what's this right here? Comorbidity, right? Is that risk factor right here? Some sensitivity to percussion. Palpation, not so much. Here you go, sir. No response to endo-ice or EPT. Maybe even laser Doppler flowmetry, you know, just to test the current. We'll just throw that in there as well. So based on this, can anyone give me a tentative diagnosis? What are we thinking? You know, is it maybe symptomatic? I don't know. Let's think about it. There's no response to endo-ice. I wouldn't think it would. Necrotic. I like necrotic. Yeah, why not necrotic? Let's take a look now and see what we think with the radiograph there. Is anyone going to argue that's a periapical lucency? I think it is, right? So maybe we would say what? Necrotic, and what would we give the apical diagnosis? Yeah, maybe symptomatic apical. However, as an endodontist, you know what I call this? This is a retreatment. So the diagnosis, that's what I'm giving it. This is going to be a retreatment. Why? Now I'm being facetious. Obviously, you could have ligated the tooth with some sort of floss, some sort of, ligand. But if you don't have rubber dam, you're setting yourself up for failure. I can't tell you how many times these cases come through my office and they failed because there was no rubber dam placed. So I'm not going to hit you over the head with that, but nonetheless, let's at least practice to the standard of care, and that is the standard of care. I have sat on a few cases with the New York County Dental Society, and we do not side with the dentist when they are in the wrong. We're very fair, and just understand that dynamic. These are just some tests that we can do to help us evaluate diagnosis. This is my favorite tool in my armamentarium because what? I can trace sinus tracts with that. I can diagnose vertical root fractures, understand how to use your endo-ice on the buccal surface. So just essentially just diagnostic tools. So before we were talking about the inverse relationship of what? Anxiety and pain. One way that we can help manage pain is by using nitrous oxide. How many of you actually use nitrous oxide within your practices? Good, doctor. And is this something that you go to regularly? Is there maybe specific cases? Do you actually feel that brings value to your practice?
Oh, yeah.
Yeah, I do too. And I think that, if we look at some of the literature, I went to Case Western, which is in Ohio, Cleveland, but Ohio State and Columbus, they are well known. Oh, was the mic not on that whole time? They are well known for anesthetic studies and also evaluating pain. So we know that nitrous oxide, it's a limited NMDA antagonist, pretty much blocker. So it's not going to allow those action potentials to actually talk. So the nerves are not going to, be communicating with each other. So you get a feeling of euphoria, right? You feel a little bit just kind of, that's the word for it. It does have a little bit of analgesic power, not much, okay, but it has been documented. Relatively safe, and like the doctor in the back mentioned, it is beneficial and good supplement for anxious patients. And if we look at the literature, what is the usual sort of spectrum or range for a successful inferior alveolar nerve block? You'd probably be surprised, but it can be as low as maybe 29%, maybe even lower, maybe extend up to maybe 60, 70, depends on who you quote. But we know that consistently achieving successful pulpal anesthesia with the inferior alveolar nerve block is a challenge, okay? And so in this study, what they did was they looked at the success rate of using the inferior alveolar nerve block, and nitrous was 50% versus the other group was 28%. Okay, so that may seem very low, 28%, but if you look at the literature, that is actually very consistent with what we see. So this is statistically significant. Why not use nitrous if you have it available? If your patients are actually using it or requesting it, sometimes you can even include that as an additional service and charge for that. So ways that we can manage patients, the literature states it. It's just a matter of you thinking, is this something that I want to introduce to my practice? Is it going to be a benefit to me? And will I be able to use it to where I feel comfortable? That's how I evaluate different armamentarium or different tools or instruments that I'm introducing into my practice. Let's go ahead and get into some real literature. I hope you guys didn't eat too much. It's going to be a little bit boring, but right now you got to pay attention because these are classic studies that we're looking at. And it's not so much about the results of the study, but the methodology of how the study was actually conducted, okay? And that's what we're really looking for. Sensitivity, specificity, predictive values, and accuracy of 3 diagnostic tests to predict inferior alveolar nerve blockade failure and symptomatic irreversible pulpitis. That's a lot. But it was a recent study in 2017. I believe it was in Costa Rica. And it was actually a very good study because what they did was a cross-sectional study. Cross-sectional studies aren't the strongest evidence, but what they do provide is it's almost like a snapshot in time of where we are. And you can use that information to maybe infer, but you cannot really show there's a direct association or a linkage, but nonetheless, it is good information. 53 patients that fit the profile, molars with what? SIP. We understand that to be symptomatic irreversible pulpitis. They had to at least rate their pain as moderate to severe on a visual analog scale. Visual analog is nice because it's going to eliminate bias. Therefore, everyone is looking at the same chart. Yes, that's where my pain is. It's not just a matter of being subjective. I kind of feel it's here, kind of feel it's there. So therefore, we're showing consistency within the responses. At the time, obviously, it was an endo resident who was completing it, but it's important to know that it was the same resident that was evaluating the case, doing the diagnostic workup, and also administering the anesthetic. For whatever reason, I didn't really see that they explained it thoroughly. They wanted to use mepivacaine, 2%, 100 with epi. Does anyone use that here? Usually it's 3% mepivacaine for us here, but nonetheless, that was what they put in the study. There were 3 different tests to detect anesthetic failure. How many of you guys rely on the lip numb test to see, oh, my patient's numb? We're going to talk about that because I think you'll be surprised. There was another group, another test was the cold test. For testing, we usually want to put that on the buccal surface if we're talking about molars, right? And the cold test is good. Anytime before I actually start treatment on my patient, I do like to at least assess with cold. We'll see how reliable it really is based on this study. And of course, responsiveness upon access, removing the filling, getting into the roof of the chamber. That was another way to evaluate the failure of the inferior alveolar nerve block. Look at that failure. Oof. What do you guys think? That's pretty much consistent with what we saw before, though, if we look at the literature. Okay. I would like to think that I'm a lot higher than that when I actually give my block. You know, if we're looking at landmarks, and we'll get into how we can ensure a more profound anesthetic shot later, but that's pretty significant right there. Gold standard was pulpal manipulation, meaning once they actually get into the tooth and they extirpate the pulp, is the patient feeling pain? And you can see that the patient was feeling pain about 70% of the time, which is a lot. So what did they conclude? Huge. No test demonstrated a high enough accuracy. None of the tests. I don't care if it's lip numbness, cold sensitivity. What else did we have? Access. None of those tests were considered a reliable diagnostic tool for the prediction of anesthetic failure. This is just a schematic, so you can kind of see they had some diagrams to actually show what they did in the categories. Again, here is the gold standard manipulation of the pulpal tissue. They did some pretty good analysis, statistical analysis. I want you to pay attention to this row right here, or column, I should say. And I think I blew it up here for you. Sensitivity, how will you define sensitivity? That's probably what the true positive rate. Those individuals who are really, in this case, if they were really numb, how sensitive is that test to detect that? And then for those with specificity is the true negative rate. For those patients that are really not numb, how specific is it at actually evaluating that? And for this study, all of these three categories were 1 for specificity, but you can see the numbers were pretty dismal for sensitivity. Okay, essentially saying that these tests are not very good predictors. But I want to draw your attention to the accuracy column. 30% of the time, lip numbness is an effective predictor. Maybe a little bit more than half, we're going to say the cold test works. And just a little bit more above that, responsiveness during access. I don't really like those results. I don't think you should either. Okay, and how many of you have ever been a patient, meaning you've had root canal treatment? It was the best experience I ever had. I'm so happy that I was in my third year of dental school, and my senior at the time, no, I must have been actually second year dental school. My senior, student was a junior, and I was one of their first patients, and I needed a root canal. I had just been eating too much candy, studying for my boards, and that was the worst experience that ever happened. It hurt like hell. And I know they didn't have any malicious intent, just that their experience wasn't there, and he really didn't know how to properly clean and shape and make sure that I was fully numb. But because I had that experience, I said, moving forward, I can never let that happen to any other patient. And so I've taken all insuredness to ensure that my patients do not have to go through that agony. So it was unpleasant. And I think that this study is going to clearly show that. Several clinical and pharmacological strategies, such as supplementary techniques or analgesic pre-medication, meaning that maybe we're prescribing NSAIDs, some nonsteroidals beforehand, are recommended to prevent painful treatments and patient discomfort. Because we just found out that no matter what tests we're using, none of them are accurate enough to really give us a thorough evaluation. Is this patient fully numb? Has our mandibular block failed? So they're recommending that we use supplemental techniques. Efficacy and safety of pulpal anesthesia strategies during endodontic treatment of permanent molars with symptomatic irreversible pulpitis. A systematic review and network meta-analysis. Okay, so we're looking at all the literature that's been put out at this time on this subject, having very strict criteria of inclusion, exclusion, and then based on that, reviewing that and running some statistics to see how valid is that information and trying to answer the question that we have. And the question that we have is the efficacy of pulpal anesthesia. So they did a comprehensive database search. Eligible randomized controlled trials were analyzed. Why do we like randomized? It's going to what? Limit bias, right? It's random. We want that. Analytics software was used to assess the quality of the results, just saying that there's a lot of fancy tests that were double checked and checked by statisticians. 37 interventions from 46 studies were identified, not the highest sample size, but again, we are looking at a meta-analysis, so we can kind of disregard that. Compared within the common practice of an inferior alveolar nerve block. So they're kind of looking at what is the standard, okay, and basing their results on that. And what do we find? A supplemental intraosseous injection. I should mention, this just came out recently in the Journal of Endodontics. And that's why I wanted to put it in here, okay, because it just happened to tie into the lecture. And the thing about the literature is that there's so many studies that are coming out on a day-to-day basis. It's hard to keep up. But that's why you have to look for trends. But what was important is they're saying that a supplemental intraosseous injection, we'll get into intraosseous techniques, of 2% lidocaine or 4% articaine, followed by a supplemental buccal and lingual infiltration. Does anyone, when they're actually, first of all, who all does root canals? Okay, good. So when you are actually going through your process of getting the patient numb, excuse me, are you routinely giving a buccal restoration, buccal infiltration? Lingual as well? Yeah, I don't usually do lingual myself. I'm hoping that I'll catch that lingual branch with my block, but based on the literature, I should know that I'm probably not going to be too successful with that all the time. Look at that, they said. Also, all that together is a superior injection technique to achieve pulpal anesthesia during the endodontic treatment of mandibular molars with symptomatic irreversible pulpitis. If we rewind back to that first case I showed you, where the individual, he came in, I did the root canal in 31. You remember that little white line that was behind it was on the distal of the tooth? Does anyone know what that was? Yes, that was the needle for the intraosseous. They are recommending, based on this study, 2019, Journal of Endodontics, Ken Hargraves, he's reviewing these studies. Brilliant man, brilliant mind. So it does have some validity. And he's actually, well, he's scheduled to speak on pain on Wednesday. So if any of you are around, please do show up for that, as well as Donald Tannenbaum, great pain specialist. These guys are well recognized within the literature and have a lot to offer. They're recommending that we use supplemental anesthetic techniques, okay? And they go on to say preoperative NSAIDs, nonsteroidals, whether it's acetaminophen or ibuprofen, we'll get into actually which combination is best and what we should actually use, with or without acetaminophen may increase the efficacy of these injections. Think about that. That's a lot. They're pretty much saying that the way you are practicing right now, if you want to ensure that your patients have pulpal anesthesia, you must include another set of into your armamentarium, and also you should probably heavily consider pre-medicating your patients. It makes a lot of sense. The challenge of obviously pre-medicating patients is, like my good friend, Dr. Brian here, we're endodontists, so oftentimes we're getting patients thrown to us same day. So we may not have the luxury of being able to pre-medicate someone, unless you want them to sit in your chair for a while. So that may not always be something that's feasible. But nonetheless, they're recommending that. Does anyone do that? Pre-medicate? Not really, right? The literature states that it's actually pretty significant. Let's look at some significant variables. Preoperative pain, persistent for more than 3 months. We kind of went over that. Chronic pain, inter-appointment pain, gender, preoperative tenderness, percussion. So you see these same themes coming through the literature. So obviously when you have patients who come in, what's the matter? I've been having pain for so long. You should already start to think that they may be more prone to having severe postoperative pain or delayed pain beyond the root canal treatment, okay? Being able to recognize where we can go and improve in our techniques. Reduction of postoperative pain by encouragement of instruction, a study of doctor-patient rapport. I put this in here just because it's saying that anxiety is a way to keep patients kind of their pain threshold at bay. Letting someone know what you're going to do before you do it. Taking the time to actually sit down and make sure they understand. There is the power of speech, and that we should really be taking our time and explaining to patients, because ultimately it allows for better understanding. They're more relaxed, the anxiety is decreased, and You can see that, the classic study back in the day. I did study at Case Western University. Very proud of that institution. And we also put out some good literature too. I did my research on immature apices and different intracanal medicaments, so it's not going to actually come into this presentation, but nonetheless, Dr. Mickle has put out quite a few studies, and we were looking at analysis of current analgesic preferences, meaning how do endodontists practice? Who would argue with me that the endodontist is not the pain expert when it comes to odontogenic pain? Right? I think that we should take pride in saying that we are. And we always want to be on top of that so that when you send a case or you have a question, we can properly answer that. Descriptive cross-sectional survey, we've seen this again. It's a cross-sectional survey. 310 randomly selected AAE members. 20%, more than 20% response rate, so you need at least 20% for it to have significant meaning to the, and I'm saying not statistically significant, but to at least say that the number of participants is valid enough so you can actually draw from the statistics. 11 different clinical scenarios were depicted, procedures, different levels of pain, and these were posed to, remember, endodontist. Different choices of meds, NSAIDs, narcotics, etc. And this was back in '06, so just keep in mind that this is something that is repeating itself throughout the literature. There was a pain scale, meaning that if they, how would they react if the patient said I have moderate pain? How would they react in terms of prescription techniques and practices if the patient said they had severe pain? Look at this. Here's the kicker. Non-narcotics were preferred over narcotics for all clinical situations. That's across the board for all endodontists. There's no need for us to prescribe narcotics. Now, I'm not saying that you guys are prescribing narcotics, but is there anyone here who regularly looks to include that in their prescription habits? Not really, right? Yeah, at this point, there's no need. And we see that in the evidence in the literature. So what did they recommend? Statistically significant p-value, less than 0.05, right? 600 milligrams of ibuprofen given 4 times a day was the preferred analgesic prescribed. That is the preference of all endodontists surveyed at that time. Now keep in mind, there was a portion of those endodontists that were residents, but nonetheless, the residents are in the literature. That's all we do is study. So they're going to try to practice to the highest level of care based on the literature, couple that with any anecdotal information, any empirical data as well, to deliver the best quality for their patients. It goes on to say, from that study, educators and board-certified AAE members were less likely than non-board-certified AAE members to manage their patients' perceived severe pain with narcotic analgesics. Now, why did they include that in there? Are they trying to boast and say, oh, if you're board-certified, it means that you're practicing at a higher level? No, they put that in there to highlight that even amongst endodontists, there is variation. And you're going to find that within the literature. There's always variation, okay? But it's up to you to make a conscientious, concerted effort to have the discipline to find the research to support what you do, to find areas where you feel you can improve. Remember, the biggest room for improvement, or stay stagnant and just continue what you're doing based on the empirical data. This works for me. Dr. Amina Sherry, Case Western as well. Not just to put Case out there, but she's amazing in terms of does a lot of work with the American Dental Association, and she pretty much is the resource on proper prescribing habits when it comes to pain medication as well as antibiotics. And so what did she say in 2016? She's the preclinical director. She said that the combination of 600 milligrams of ibuprofen and 1,000 milligrams of acetaminophen was more effective at pain relief than 600 milligrams of ibuprofen alone. So that is the standard. That's what we're going with. I like this myself. We'll see other studies that show a different number, but pretty much 600 is the number we're going for. When you couple that with 1,000 milligrams of acetaminophen, yes?
Would that be Q8? Is it administered every 8 hours? Because 1,000 seems like it would be a lot.
That's a good question. if we look at that 1,000 milligrams, that would be what? 2 extra strength tablets. So ideally, when I was in residency, 2011, I know I got the young face, but I'm almost in my fourth decade of life. It was 4,000, but they recently changed the maximum daily dosage to 3,000. So I guess you could work it out to, 3 times a day if you want, or you can do what Cooper advocates, which is flexible prescribing, or Hirsch. Maybe you'll take the Motrin, and then 2 hours later, you'll go ahead and take the acetaminophen. So this way you're kind of balancing that out, and this way you're not always specifically trying to get in 4 times a day. You'll more or less get into 3 times if you take the ibuprofen first and then switch over to the acetaminophen. But I think it's a good point that you bring up, but just understand that is the minimum effective dose that they're recommending. And so however you prescribe it for your patient is kind of up to you how you want them to comply. But it doesn't seem high to me. I think that falls right in line.
I read an article recently where they went even more conservative and they said 400 ibuprofen and 325 acetaminophen. Is that too conservative?
There's a study that I'm going to highlight, I think, next, and they actually talk about using 400, and we'll kind of see what the difference is. And that's why I wanted to start off with this study first, just to show you how endodontists think. We already did come to the agreement that the endodontists are the pain specialists, right? We said that we are the experts in pain. So by and large, this is what most endodontists use. Is there any other endodontists aside from Dr. Shigezi in the room? No. Doc, if you don't mind, when you do prescribe, 600, 400, 800, does it really matter?
So I do 600.
Yeah.
But I mean, if the patient told me I've got 800s at home, cool.
Yeah, it works.
I typically only do 500 acetaminophen every 6 hours.
Gotcha. Yeah. And so I think that we can all pretty much say, if I were to ask probably, I think 10 endodontists, 8 of them would say they use 600. Now we may differ in terms of where we prescribe for the acetaminophen. You may not even recommend that at all. As you heard Doc say, 500 works for him. But like I said, I pose it upon you just to look at the literature and find out what really works for you. But Doc, we're going to get into your question next about the 400 and the 325. So this was from a journal just called Pain. So obviously there's probably some significant studies in that, right? It's just called Pain. A randomized 5 parallel group placebo-controlled trial. I don't want to read all that. Pretty much it's a high quality study. That's what they're telling you. Thing is, it's not specific for root canals, but nonetheless, dental pain, we understand that NSAIDs are going to be more specific for what type of pain, oral pain. So we can still apply this study. Third molar extraction model, placebo-controlled trial. Look at the number of subjects they had. I think that's pretty good sample size, 678. Different groups. Remember, again, you had at least experienced severe or moderate pain, visual analog scale again, and usually within 6 hours of completion of surgery, that's when they're kind of evaluating the pain level. Just to make sure that the patients don't start to question what they're receiving, everyone had 2 white tablets that are of the similar size, but again, we know that there's a placebo worked into that as well. And then they would rate their pain at 0.5, 0.75 an hour, 1.5, and then after that, 2 hours after, every 2 hours. There you go. There's your 500 milligrams, okay? Now, acetaminophen, 1,000, again, is what they're saying. These ranked the best from worst. These were the different groups. The placebo was down here all the way last. They even put codeine in there as well. 200 milligrams, 500. So they really didn't actually use 325, but you can see that 400, which is what you mentioned, is there. Now, some of the literature that I looked at, I did see that there was a significant difference in the minimum efficacy or minimum therapeutic efficacy between 400 and 600, but not necessarily 600 and 800. But if you can get effective pain relief from 400, why not? Does anyone know the maximum dosage for ibuprofen 24 hours? Most likely it's going to be 3,200. 3,200 is the usual recommended dose, or you don't want to exceed beyond that. So you can play a lot with 400 milligrams, and if you're prescribing that 4 to 6 times a day, obviously you're going to get a few doses in 24 hours. Let's look at the chart from that same study. This is important. Pain relief hours after taking the drug, meaning not only how effective is it, but how much of a penetration, how much of an impact does it have long lasting. If we go across, remember this is like a half hour, an hour. At 8 hours, they still rate their pain as about 1.8, but they're getting, they're still having some effect from that analgesic, as compared to any one that has narcotic in it, it's going to be lower. And obviously we can see the placebo where that fails. So I think that as long as you're using 400 or 600 ibuprofen, you don't necessarily have to couple it, but if you do want to use, I would say, Dr. Paul, I would say at least try to stay within 500 milligrams to 1,000. 325, to me, it seems a little bit under dosing. But I'd love to see that study if it was maybe JADA or where it was from, just to see the power ranking or the ranking of the impact factor. That's what they call it, of that journal. Percentage of the subjects from that same study needing rescue medications any time between 1 and 6 hours. What do we find? Again, with that nice combination, 15% needed to be rescued. And I think it's important to note that the rescue medication was tramadol. I don't know why they used that, but that was just it. I think they used another one too. I can't recall 100%. But you can see when they actually used Ibru 400 or acetaminophen, narcotics didn't give you too much of a consistent relief. So why do we even prescribe Vicodin? I just took a generic poll of the lecture room right now, and most of you raised your hand when I said, do you not prescribe? And you say, yeah, we don't prescribe narcotics anymore. Okay? And I think that we've done a pretty good job getting the word out, also doing a public service awareness campaign. And now we have seen a significant decrease. But why were we prescribing? Was it because we wanted to manage patient expectations? The patients come in asking for it. Was it that we want to ensure their satisfaction? Maybe it's even fear of bad reviews. We do live in a society where social media has a huge impact on patients' choice in selecting a provider. Look at this, though. This was a study. And whenever you see these names, I love Cooper. You talked about the flexible prescribing, Hirsch, Paul Moore. These are well-recognized clinicians and scientists within the field of pharmacologics, okay, in terms of dental. And they looked at, they reviewed some literature, meta-analysis, and they said, surprisingly, we could find no references in the literature in which investigators found that hydrocodone with Tylenol combinations as currently prescribed and formulated to be more effective than non-steroidals. So relying on non-steroidals rather than opioid pain relievers does not add to our nation's ongoing prescription opioid abuse epidemic. Okay, so these are the experts, and they're saying that they can't even find anything in the literature that shows that you get better pain relief by using a narcotic. And so even in my practice, I have 3 dentists that work in the practice in addition to myself. Sometimes they'll ask me, hey doc, I want to write a prescription. I say, no way. We know that there's no reason for us to give a narcotic. If the patient doesn't like it, I'm happy to dismiss that patient. I don't want to work with someone who doesn't respect our professional recommendation. Again, another study, recently, April 2018, some of the same names, a little bit different. What did they see? The best available data suggested that the use of non-steroidal medications with or without acetaminophen offered the most favorable balance between benefits and harms, optimizing efficacy while minimizing acute adverse events. So essentially the same thing. So the literature is replete. We have I guess, practice. So let me just a couple more studies there. New England Journal of Medicine, the Journal of American Medical Association as well. Dentists have already have written, actually less than 500,000 fewer opioid prescriptions over a 5-year period, which is phenomenal. We should applaud ourselves on that. So what the literature that has been put out has been received, and by all means, dentists are complying. And when we see the compliance, we also see the decrease, and that's only just going to be less of a risk for our patients. So in March 2018, what did the ADA do? They adopted a policy making it mandatory that we have CE regarding opioid prescriptions. Limits on prescribing. You can't really prescribe opioids for more than 7 days. And also, dentists registering with and utilizing prescription drug monitoring programs, okay, to help promote what we call, I should say, prescription stewardship. So now that we've figured out the best combination to manage our patient's pain, let's look at the predictors of identifying that pain so that we can properly treat and make sure they have a comfortable postoperative experience. Landmark study, Rosenberg, Scherzer, Leung, Babick, out of NYU. And what did they find? What were they doing? They were trying to understand the effect of occlusal reduction on pain after endodontic instrumentation. Being that this is New York, I know that we do have some individuals not from here, but is anyone familiar with this study? So good, we'll go over it. More than 117 subjects needed root canal, and there were specific clinical findings were recorded, meaning that some of them came in with abscess or they came in with, just different presentations, okay? But there were specific inclusion and exclusion criteria. But they decided to only go with 4 categories: pulp vitality, preoperative pain, sensitivity to percussion, and the presence of what? Periapical radiolucency, okay? So those are the 4 predictors that they were looking at, or they put into a category. Obviously, teeth that were excluded, you don't want anyone that has restorations that needed to be maintained, crowns and things of that nature, because obviously if a crown needs to be maintained, you can't do what? Reduce the occlusion. And the whole point of the study is to see the effect of occlusion reduction. Pocketing, because some of that pain can be attributed to what? Periodontal concerns. Retreatments, none of that was allowed. 3 different groups. Total occlusal reduction, meaning that you can see light. You look through, there's no contact, not even non-functional cusp. Simulated, that's what they're doing, is pretty much reducing non-functional cusp, or actually running a burr along the tooth so that the patient at least feels that their tooth is being reduced. Or group 3, the occlusion was never touched. Then they had them answer a questionnaire, and then they recorded the pain. Occlusal reduction should prevent postoperative pain. They arrived at this conclusion when teeth exhibit pulp vitality, percussion sensitivity, and we've seen this now over and over, the idea of the percussion sensitivity, preoperative pain, absence of what? Periapical radiolucency. Now, some of you may find that counterintuitive, absence of a periapical radiolucency, but there's a lot of data, even I think as of late, Dr. Ozma Khan, who's a phenomenal researcher in endodontist, who shows that there's an inverse relationship when you have a larger periapical lesion. By every millimeter that it increases in size, the patient is less likely to report severe postoperative pain. Okay, so just because you see a large lesion, don't reach for those antibiotics. We can get into that a little bit later. That's it for another course about when to prescribe and how to effectively prescribe antibiotics. But by and large, we're seeing that with those large periapical lesions, the pain is not as severe postoperatively. 27 of those teeth had all 4 characteristics. And what did they find after occlusal reduction? What does that say? None of those teeth had postoperative sensitivity. So without a doubt, someone comes into my office, "Doc, I'm having pain when I bite." I'm taking it down. There's not even a question. And it's not just because of this, it's also the empirical data that I see on a day-to-day basis, just knowing that this tooth needs to be reduced in order for that patient to have a successful, uneventful recovery. Alan Law, Nixdorf, you guys familiar with these names? Great pain experts within endodontics. And this was very interesting because they are part of the, it's the public, the network of dentists, problem-based network, where you essentially have dentists reporting their findings from the clinical aspect. So the information is very relevant. Okay, it's a consortium of doctors, meaning it's not just endodontists, it's also general dentists as well, and they all report their findings. And after they adjusted for everything, look at the independent predictors for severe acute pain. Remember what I started off with? What does this mean right here? The anxious. Just substitute that for anxiety. Patients who come in with high anxiety, if we look at the adjusted odds ratio, they're almost 2 times as likely to what? Have severe acute pain. Okay? So understand that dynamic of managing someone from the psychological aspect. Now, sometimes we end up just managing them from a psychological aspect. They just want to come sit down and talk. I get those patients too. They don't even want any root canal. They just want to talk. But they still do get hit with that consultation fee. You got to keep it real. Time is money, right? But no, it's an important part of what we do. Obviously, when you are going to report severe pain, you're more than likely to have, look at that, almost double. It's crazy. Acute pain. Female gender, again, we see that gender does play a role. To what extent, it's hard to say, but we can see that it's there. Look at this. This is great. When you go through life with a positive outlook, I think that ultimately things open up for you. You have a good experience. And we even see that mirrored in dentistry. When a patient expects a very good outcome, look at that. The odds ratio decreases almost to half. How do you explain that? Magnification. Why is this important? Because you're more likely to what? Find accessory canals, additional middle mesials, MB2s, things of that nature. Even evaluate for cracks. So if the tooth is cracked and we find out we can't save it, send it for extraction. They're not in constant pain. So there is a lot of importance to a magnification, meaning that a microscope is a definite asset when doing endodontics. This one is the only one where it draws a little bit concern, and why is that? Why do you think that single visit root canal is so high in terms of postoperative pain, severe pain? Well, the way the study was conducted, the methodology, patients reported their pain after obturation. Okay, so we can say that these results really aren't as valid as we like, because if you do a single visit root canal, obviously the pain is going to be most intense at that time versus someone who comes in for an appointment, calcium hydroxide, then they report their pain after they present to have the tooth obturated. Usually within a week, the pain should subside. So again, that's why this odds ratio is so high, because that's probably a little discrepancy that wasn't accounted for enough. The patients were responding at the time of obturation, not the time of leaving the dentist's office. Okay. So here's the chart that maybe you all should take a photo of. This is from the American Association of Endodontists. We already established that we are the experts in managing pain. And this was our latest AAE update, Colleagues for Excellence. I did leave off, I think, another drug. Might have been another variation of acetaminophen and codeine. But by and large, these top 2 are the ones that we're going to stick with. We're going to prescribe those. Okay? Tylenol 3, Vicodin, acetaminophen. Again, you can use those, but we should really be focusing on ibuprofen, acetaminophen, those non-steroidals. Okay. So I really appreciate we at least had to get through the pain management aspect. I think that we all can come to a general consensus that pain management is something we all have to have a strong hold on within our practice. However you go about that, achieving, profound pulpal anesthesia. We'll get into some techniques in the next session. But right now, if you guys want to take a little break, feel free. And I think we'll just come back in like 5 minutes or so. Okay.